So very happy afternoon to all doctors. I'm Dr. Priyanka. I'm working in the Electronic City branch of Garbhagudi, and today we'll be discussing about PCOS and infertility. It's a very vast topic. Too many things to be dealt with. I mean, there is almost loads to speak in pathophysiology, and then talking about infertility, I have emphasized more upon the recent guidelines. And let's see if you can understand, and we'll take up the questions later. So starting with the introduction, it was first described by Irving Steen and Michael Leventhal as a complex syndrome of anovulation in 1935. And the prevalence is up to 4 to 18%, and in South Asian women, it is up to 50%. And among the obese, the prevalence is more, that is around 28% versus 5% in lean women. And it contributes substantially to infertility and accounts for 90 to 95% of the women attending infertility clinics with anovulatory cycles. And India has witnessed a rise in about 30% cases in the couple of years. So what is the exact pathophysiology for it? So it is not a single factor which causes PCOS. As you are all aware, there is an interplay of various factors like genetics, then the lifestyle and environmental factors, together with the alterations in the neuroendocrine mechanisms, and further accentuated by obesity. So all these together contribute to the syndrome of polycystic ovarian disease, or polycystic ovarian syndrome is what we call. We don't use the term PCOD anymore. And the compartment wise, if you would classify where all could be the problems in PCO, it could be in the central compartment, that is in the hypothalamo pituitary region. Problem could be in the ovaries, adrenals, or in the peripheral adipose tissue. So what could go wrong in hypothalamus? In hypothalamus in women with PCO, it has been found that there is an increased pulse frequency of GnRH. And because of which there is also associated increased sensitivity of the pituitary to GnRH, due to which there is an increased pulse frequency of LH, which is preferential to FSH. So the LH levels rise more as compared to the FSH levels. And these are the various mechanisms, and which in turn is again stimulated, and this pituitary. So in addition to the hypothalamic stimulation, because of the high estradiol and high estrogen also, again, there will be stimulation of LH release. And increased pulse frequency might reflect either there is an intrinsic hypothalamic dysfunction, or there could be abnormal feedback signals from the periphery, or it could be a combination of both the factors. So as a result of these hypothalamic alterations, there is a steady state endocrine milieu in the pituitary. So on the left of the figure, you can see that these are the normal hormonal variations which you see. So in the follicular phase, there is a gradual rise in estradiol, and just before ovulation, the peak rises, and similar, the LH peak happens, and then it has to come back and settle. Then there is a gradual rise in FSH, which should happen. But if you see on the right side of the figure, this is what happens in PCO. There is a persistent or sustained LH rise. FSH is slightly elevated, but it is almost like low or normal to the baseline, and it almost remains at the same level. And even the estradiol and progesterone levels do not fluctuate much. It is just a steady state due to persistent anovulation. So this increase in LH levels, what does it indicate? It is there are abnormal secretory dynamics, because of which there is an increase in LH pulse frequency, and also sometimes an increase in pulse amplitude. However, that is to a lesser extent. And due to increased pulse frequency, more basic LH isoforms are secreted, which tend to have a greater bioactivity, and so the LH action is predominant here. And the FSH levels are lowered as compared to LH levels, because then, as we know that here the increased pulse frequency is favoring more of LH, and also a negative feedback which affects the chronically elevated estrone concentration, and there is a normal or modestly increased levels of inhibin B also, which is derived from small follicles. And to see how what all is seen in PCO. So in 75% of the women, there will be increased LH concentration. In 94%, it will be the ratio which is increased, that is LH increase is more as compared to FSH release in 94%, and low or normal level of FSH can be seen in some women. So these are the various clinical like biochemical parameters which we could come across. And so that was the changes in hypothalamus and pituitary. Now what happens in the ovary is, because of increased LH stimulation, there will be increased LH stimulation of the ovary. There is dysregulation of the enzyme cytochrome P450 C17. There is increase in insulin-like growth factor 1, increase in androstenedione and testosterone levels. The insulin levels are increased, that is, there is hyperinsulinemia, and there is a decreased aromatization. These are the various actions which happen at the level of ovary. So when the FSH is low and the LH and the insulin-like growth factor 1 levels are high, so when the FSH is low, the granulosa, it mainly acts upon the granulosa cells. So as this action is lesser, so there is lesser follicular maturation, lesser aromatization, because of which the estradiol levels are low and the inhibin levels are high. And because of increased LH, which acts mainly on the theca cells and on the stroma, there is increased androgen production. And these excess androgens then convert into more potent 5-alpha reduced androgens, which further inhibit the aromatase activity and prevent progressive follicular development. So as you know, during the follicular development, initially it is the granulosa cells which will undergo proliferation. And as the estrogen level rises because of the conversion of androgens to estrogen, there is the estrogen surge and the LH surge which happens. But here, because of the inhibition of the aromatase activity, there is not the conversion of androgens to estrogens is not happening, because of which the further development of the follicle does not happen in PCO. And granulosa cells are sensitive to FSH and insulin-like growth factor 1, and they produce estrogen, but they cannot generate and maintain the estrogenic follicular milieu to achieve advanced stages of development. So what happens, only up to a particular stage, the follicular growth happens. So new follicular growth continues, but it will arrest before the full maturation only. And that is the reason why we get multiple small follicular cysts, which would vary between 2 to 10 mm in size, and they will be surrounded by the hyperplastic theca cells, because they are being continuously stimulated by the increased LH, and they are continuously being luteinized. So, and as they are getting recruited and they are not becoming dominant, they undergo atresia. So these atretic follicles form the ovarian stroma, which gradually increases in volume over time. And because of the increasing androgen producing cellular mass, there will be more and more of ovulation, which will be happening. So what happens at the level of oocyte? So in the oocyte, the gene expression is dysregulated in PCOS. The oocyte secreted factors may contribute to the aberrant follicular genesis in PCOS. So there is GDF9 and BMP15, which are important oocyte secreted factors, and they are required for normal cytoplasmic maturation. And when normal follicular genesis has to happen, both these levels have to decrease at the M1 stage and they have to increase in the M2 stage. And in PCOS, this is not happening at a proper rate, and so it is reduced without any dynamic change. And this may be one factor which has been suggested to be contributing to the symptoms or the dysregulated mechanisms in PCOS. And what is the role of AMH in PCOS? So as the LH and insulin levels are high, there is more and more of androgen being secreted. Multiple small follicles are growing up to a particular stage, and these will go on secreting AMH. And that is why the AMH levels are very high in PCOS, because the PCOS can be, the AMH can be secreted by the small andral follicles as well. So the more the number of small andral follicles, the more will be the AMH. And because of which there is a decreased FSH action and there will be anovulation. And also in PCOS, there are insulin secretion abnormalities. The main pathophysiological mechanism is insulin resistance, which is quite common, more so in obese and less so in lean women with PCO. The overall prevalence of insulin resistance is almost 50 to 70%. And 35% will have impaired glucose tolerance, and up to 7 to 10% may even have type 2 diabetes. And the risk of type 2 diabetes is almost six-fold increased in women with PCOS. So very important to test the sugars, and more importantly, rather than doing a random blood sugar or a fasting and postprandial, it is important to do the glucose challenge test in women with PCOS. So this is the normal mechanism of insulin. I'll show in this figure. So normally insulin binds to its receptors. There is tyrosine phosphorylation, and insulin will then bind to the receptor substrates with the p-tyrosine residue, and phosphatidyl inositol 3 kinase acts, and with the AKT there is metabolism which happens, that is the glucose metabolism. However, in PCOS, because of the resistance, there is more of serine phosphorylation rather than tyrosine phosphorylation. And this PI3K mechanism which was happening, this does not happen. So because of the serine phosphorylation, there is more and more conversion of more and more formation of androgens. This is another flow chart which is showing, actually this showing the action of metformin, but just to explain what really goes wrong in PCOS. So on the right side of the figure, you can see normally there is increased insulin and increased IGF-1 levels in PCOS. Because of the hyperinsulinemia, there is inhibition of action of this cytochrome P450 C17 ligand. This enzyme is less active, because of which more and more androgens are being formed, and they are not converted, and because the aromatase is deficient, these are not converted into estrogen. And also because of the high insulin levels, the sex hormone binding globulin levels are also low, because of which there is more of testosterone which is available. So metformin, when we give to such women, it will help in controlling the high insulin levels. Metformin will also act on the aromatase, and it will also help in the metabolism, or it will reduce the gluconeogenesis, and it will reduce the fat synthesis which happens in case of PCO, and hence will alleviate the symptoms. So because of hyperinsulinemia, there is increased GnRH transcription through the mitogen associated protein kinase pathway, and because of which there is increased androgen levels. Because of increased ovarian androgen production, there is a decreased SHBG production, and it potentiates the action of LH, and they act synergistically to stimulate the androgen production. And even on the adrenal cortex it can act, and the sensitivity to ACTH is increased, and there is inhibition of the hepatic production of the insulin growth factor binding protein. So when there is decreased production of the binding protein, the levels of IGF-1, that is insulin-like growth factor, become high. So that contributes to the hyperinsulinemia and the various symptoms of PCO. So all this would result in high androgen levels, resulting in the clinical symptoms of hirsutism, acne, male pattern balding or alopecia, and almost 60 to 80% of the women will have high androgen levels. Free testosterone levels are the most sensitive among them. And in addition to these hyperandrogenic features, there may rarely be also increased muscle mass where it has been prolonged. The hyperandrogenism has been prolonged uncorrected. There can result even in increased muscle mass, deepening or worsening of voice, and clytomegaly. So this is the androgen cycle. So what happens? There is peripheral insulin resistance, because of which the levels of glucose go on rising in the peripheral blood. There is increased insulin secretion in the pancreas, and this increased insulin will again result in excessive androgen production from the theca cells. And in addition, there will be decreased SHBG levels in the liver with the free high androgen levels, which will in turn potentiate this insulin resistance. So the cycle goes on. And when there is obesity, the chances of insulin resistance become higher, in addition to the basic pathophysiological mechanisms in PCO. So these all actions get aggravated. So again, the same mechanisms, the SHBG levels will be low, and also low levels of insulin-like growth factor binding protein, because of which there will be hyperinsulinemia and high androgen levels, and also increased production of androgens from the ovary. So how do we diagnose? One thing which we have to keep in mind is these women will be at high risk for infertility because of anovulatory cycles. They will be at risk of DUB because of the chronic changes in the, or the basically the change in the hormonal metabolism, or the internal milieu of the hormones is altered because of long duration of non-shedding of the endometrium. They are prone for hyperplasia, and then later in life they may develop endometrial cancers, obesity, type 2 diabetes. So the entire metabolic syndrome where hypertension and cardiovascular diseases can happen. And it will also have implications on the first degree relatives, especially their sisters and daughters. So it has to be a whole like a complete counseling, and we have to counsel them as to how it will impact their family members as well. And hence for them we can offer screening at an earlier age, and they would probably need lifelong treatment in the form of insulin sensitizers. So how do we diagnose this? So there are various criteria which have been suggested, and the basic diagnostic factor in all of them is clinical hyperandrogenism. Here HA stands for hyperandrogenism, OA is for oligo-ovulation or anovulation, and PCOM is polycystic ovarian morphology. So in 1990, National Institute of Health has suggested that if clinically there is hyperandrogenism, along with that there is oligo or anovulation, if both the criteria are met, then we could diagnose PCOS. Then in 2003, ASRM and ESHRE guidelines suggested that we must also see ultrasound features of PCO, and only if two of these among three features are present, then only we can classify them as PCOS. Then the Androgen Excess PCOS Society 2006 guidelines were laid down, where again they suggested that you can either have ovarian dysfunction in the form of ovarian dysfunction would mean definitely oligoanovulation and or PCOM. So they emphasize that clinically there should be hyperandrogenism, and either of the two, again more or less similar, ovulatory dysfunction or PCOM can be there. So if two of these criteria are there, then we can diagnose PCOS. Then the National Institute of Health in 2012 changed the criteria, and they also included specific phenotypes. They said that we must classify the phenotype also. I mean, first we have to diagnose PCO, and once we have diagnosed, we should classify them phenotypically also. So what were their criteria? They said again, among these two criteria, if they are present, then we can diagnose PCO. That is hyperandrogenism, ovulatory dysfunction, or PCOM, that is PCO morphology on scan. And once we have identified PCO, the phenotype A would be women who have clinical hyperandrogenism. They will be having ovulatory dysfunction plus PCOM. So these are the type A is the classic PCO, where all the features of PCO are present. The phenotype B is where you don't see the ultrasound features of like the polycystic ovarian morphology is not seen on scan, but clinically they have the symptoms as well as ovulatory dysfunction. Type C is where you have clinically hyperandrogenism will be there along with the ultrasound morphology, but they may be still ovulating. So despite the polycystic morphology, they might still be ovulating. So these are the ovulatory PCO. Then phenotype D is where there will be ovulatory dysfunction with PCO, but clinically they will not be hyperandrogenic. So these are the 4 phenotypes. And this is what has been explained here again. So the classic PCO, the essential NIH criteria, then we have the ovulatory PCO, and the 4th type is the non-hyperandrogenic PCO. Where, so these are for the adult, and these are also called as the Rotterdam's criteria. Whereas in adolescent, it has been suggested that it may be an unexplained combination of abnormal uterine bleeding pattern, which may be abnormal for their age or their gynecological age, and the symptoms must be present for at least 1 to 2 years. And especially like in the first 2 years, we should not be considering it. After 2 years of attaining menarche only, if the symptoms are persistent for 1 or 2 years, only then we can diagnose PCO in them. Or if there is evidence of hyperandrogenism in the form of persistent testosterone elevation above the adult normal values based on what reference lab values have been given, or there may be moderate to severe hirsutism, which would again suggest clinical hyperandrogenism. Even in women, post-menopausal women, it has been suggested that if 2 of these criteria are present, then even they may be diagnosed with PCOS. So, but what we must keep in mind is that PCOS should be a diagnosis of exclusion. We have to rule out other causes. What else could be causing the hirsutism or the hyperandrogenic features? So like hyperandrogenism would be suggested by these clinical findings of hirsutism, acne, or alopecia. Then we have to do biochemical tests to find out or confirm. And then on ultrasound, if we are able to see a polycystic ovarian morphology, that is the follicle number per ovary. FNPO is follicle number per ovary. So when we do an ultrasound and we find there are more than 20 follicles, this is what has been recommended in the ESHRE 2018 guidelines. If there are more than 20 follicles of about 2 to 10 mm size, then we would say that it is PCOM. Otherwise, they have also suggested that we check for the ovarian volume, and on ultrasound, if you find that the ovarian volume is more than 10, then again with slightly higher number of follicles, then again by the old criteria, we can still classify them as PCOM, and also stromal thickness. And biochemically, there could also, we could do tests for androgen levels, then for gonadotropin levels, that is the FSH-LH ratio on day 2 or day 3. AMH level can be done on any day of the cycle. Then check for insulin resistance by doing OGCT, or you can do a serum fasting insulin level, and check for dyslipidemia. And the other clinical presentations would be, as is very obvious, menstrual irregularity, infertility, obesity, and look for acanthosis nigricans. So how do they present with the ovulatory dysfunction? So they would have a cycle duration of more than 35 days. And if it is a cycle duration of 32 to 35 days, we have to check whether ovulation is happening or not. And how can we do that? By checking the progesterone levels in the mid-luteal phase. If it comes as more than 2.5, that means they are ovulating. And if it is more than 7 nanogram per ml, then it would suggest that the luteal function is normal. Or we could take a sum of 3 consecutive serum values. If it is more than 15, that means they are ovulating. In 10 to 15% hyperandrogenic women with apparently normal cycles are anovulatory. So some women who are hyperandrogenic and the cycle duration will be normal, but still they may not be ovulating. So it's very important to test whether they are ovulating or not. So as I was saying, that they may be having regular cycles and still not actually ovulating. So we have to confirm with the progesterone levels. So this is what I was mentioning. So the follicular threshold should be 20 follicles per ovary on 3D ultrasound or even on 2D, or up to 9. This was suggested in 2006 14 sterile, it was published. And on 2D ultrasound, it has been suggested up to 19. If you find more than 19 follicles, then we can say as PCOS. And why is there a difference in threshold? Because there would be difference in counting methods. So there could be inter-observer variations, or if your scan is not like you've not used the correct frequency, then you may not be able to pick the very small follicles, and that's why the follicle count would vary. And it also depends upon the recruitment or composition of the control population. So this is one image where you can see here, this is the normal ovary, where in one plane we can hardly see 3 or 4 follicles. But here in PCO, you can actually count there 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 follicles I can see in this plane itself. And the other feature is you can see the follicles are all peripherally arranged, but in normal ovary, you can see it is all uniformly distributed. Here, this central part, which you can see the stroma is thickened and all follicles are like very small and they're more peripherally arranged, which would again suggest PCO. So gonadotropins, as we discussed, LH will be high, FSH will be lower, and this will be seen in almost more than 75% of the women. And this LH pulse amplitude is increased more in women with lean PCO. So these are the various biochemical changes which we come across in the various phenotypes. And the elevated androgen levels will be present in almost 60 to 80% of the women. And what all can be measured? One thing is the total testosterone. So this will be the total testosterone, of which 60% is bound to albumin, 40% will be bound to SHBG. So as I discussed in the pathophysiology, the SHBG levels are low. So what happens? There will be increase in the free or unbound portion. So we need to test for the free testosterone also. So these are the various tests which can be done. We can test for the total testosterone. However, free testosterone is most sensitive. Then testing for the androstenedione levels, where the detection rate is only up to 10%. We can check for DHEAs and 17-hydroxyprogesterone if we are suspecting congenital adrenal hyperplasia. In the ESHRE 2018 guidelines, they have recommended the test which should be used to diagnose biochemical hyperandrogenism is calculated free testosterone, free androgen index, or calculated bioavailable testosterone. If the total or free testosterone is not elevated, then androstenedione and DHEAs could be considered, but these will not give much of information. And what would be the limitation in measurement of androgens? One thing is because there are different types, the total testosterone is there, we have the free testosterone, the androstenedione, DHEAs, so many are not considered useful. Then even in different populations, there will be wide variations, and it would even vary based upon the age and the BMI. And each lab will have a different set of values. And if a woman has been treated with OCPs, then the androgen levels will be suppressed. So it is important whenever we are doing testosterone levels or androgen levels in women for diagnosis of clinical hyperandrogenism, we have to stop the OCP for at least 3 months and let the levels come back to normal. Only then you will get the actual values. Otherwise, we will get wrongly low values. Then metabolic evaluation is important. We have to check for the waist circumference and the BMI. And whoever are obese, we must do a like total lipid profile in the fasting levels. And 2 hour 75-gram glucose tolerance test has to be done to assess for this one abnormal glucose tolerance. And when we consider, as I was saying, it is a diagnosis of exclusion. We have to rule out adrenal causes for it, which could be congenital adrenal hyperplasia or Cushing syndrome. It could just be obesity related androgen excess because of insulin resistance, the hair-Ann syndrome, which is the metabolic syndrome in women with obesity, or it could be drug induced due to androgens, or it could be just postmenopausal, or it could be due to pituitary tumors. So we have to exclude based on the clinical symptoms, as well as the values of the androgens would all guide us to identify whether it is PCO or whether it is due to some other hormone or endocrine disorders. Now coming to the management. So as I have put in the first, lifestyle modification is very, very important in women with PCOS. We need to manage their insulin resistance also. And if they come to us for infertility, then there is an entirely different set of management for them. And in case they are not keen on fertility, then we have to manage based on the symptoms which they have, whether they have come to you for hirsutism or for acne or menstrual irregularities. The management would further base upon that. But here we would stick on and emphasize more upon how we would handle infertility in women with PCOS. So lifestyle modification, as I said, is of utmost importance. And what is to be done? So very importantly, they have to restrict the calorie. They have to consult a dietitian, and they have to take a diet chart based upon their calorie requirements and based upon their weight. So it has to be a customized diet chart. We cannot give a generalized advice to everyone. And next is the emphasizing the importance of physical activity as well as behavioral modification. So how would that help? A reduction in up to 5 to 10% of body weight over 6 months can help in re-establishing the ovulatory function as almost more than 50% of the women. So that is why the importance of losing weight in these women. So many a times they would conceive naturally itself rather than doing advanced treatments for them. And what should be the dietary goal? They have to consume monosaturated fats, low carbohydrate diet, more of vitamin B supplements. We have to emphasize upon micronutrient supplement like calcium, then zinc. Vitamin D supplementation is very important. And they have to take more, decrease the ratio of omega-6 to omega-3 fatty acids. And they need to reduce the caloric intake, reduce saturated fat, reduce cholesterol, and reduce high glycemic index food. So they should consume more of low glycemic index food. And this was a study published in Fertility Sterility 2018, where they have emphasized and they have come out with exactly the number of hours or the number of minutes based upon the body type and the age which they should undergo to prevent the weight gain. So for adults between 18 to 64 years, the recommendation is if they are doing moderate intensity physical activity, then it should be at least 150 minutes in a week. Or if they're doing vigorous activity, then 75 minutes in a week will be important. So say at least if vigorous activity they are doing 5 days a week, 15 minutes would be sufficient. Okay. And if they are doing moderate activity, then at least on 5 days of the week, if they are able to do moderate activity of 30 minutes, that would be sufficient. And in addition to this, they would require muscle strengthening activities on 2 consecutive days per week. For adolescents, the levels are different. They are recommended that up to 60 minutes of moderate to vigorous activity or 10-minute bouts of around 1,000 steps 30 minutes daily is recommended, including those that strengthen the muscle and bone, at least 3 weekly. And for modest weight loss, it is recommended that at least 50 minutes per day, if they are doing it for 5 days in a week of moderate activity, and 30 minutes per day for 5 days if it is vigorous activity. So what pharmacological agents can be used? These are the various agents like orlistat, rimonabant, sibutramine, and acarbose and metformin. So what we commonly use is the insulin sensitizing agents. So this is what was published in the 2018 ESHRE guidelines, and I'll emphasize more on this guideline only because these are the latest guidelines for PCO, and I would suggest all of you to go and read. It is very concise and you will get a lot of insight about how to clinically manage these women. They have emphasized on each age group, what would you do in an adolescent, in an adult, in a postmenopausal lady who had PCO, how would you monitor them, and counseling. Everything has been given in detail in the guidelines. It will be free download if you type ESHRE guidelines for PCOS 2018. So CCR means clinically recommended criteria. So anti-obesity medications in addition to lifestyle could be considered for the management of obesity in adults with PCO after lifestyle intervention only. So first is lifestyle intervention, and in addition to that, you can recommend them as per the general population recommendations. CPP means clinical practice point. For anti-obesity medications, cost, contraindications, side effects, and the variable availability and regulatory status needs to be considered, and pregnancy needs to be avoided when these medications are being taken. So obviously a woman who comes to us for infertility treatment, we would not recommend them the anti-obesity medications. In morbidly obese women, bariatric surgery has shown to have good results, and a Cochrane review of surgery for obesity showed significantly higher weight loss after surgery for patients with a BMI of more than 30 kg per meter square. So either a laparoscopic gastric bypass can be done, a sleeve gastrectomy, or a gastric band, adjustable gastric band can be introduced. So these are the bariatric surgery options. And as we have understood, the central pathophysiological mechanism is the insulin resistance. So we have to correct that, and that would be possible by using insulin sensitizing agents. That is metformin. Then we have thiazolidinediones, that is rosiglitazone, pioglitazone, and troglitazone. These are mainly the diabetic medications. Then inositols like myoinositol and D-chiroinositol and acarbose. And these medications would act upon the signaling transduction pathway, and there is translocation of GLUT, and so the glucose metabolism is improved with these medications. And how would metformin help? As I had shown in the previous figure also, it will reduce the insulin resistance, or it will improve the insulin sensitivity. It will reduce the levels of insulin and also the levels of androgens. And as the levels of androgens will reduce, so hirsutism will reduce. And when the insulin levels are lower, androgen levels are lowered, the ovulation will be better. OHSS risk is reduced in these women, and the pregnancy rates are better when we have used metformin. So whenever we use it, we can either start with 500 mg. Initially, it is recommended that we use it at a lower dose for 4 days and then make it twice a day. And we can consider up to 850 to 1000 to reduce the side effects. Gradually, if we increase, the side effects will be lesser, the tolerance will be better. The other drug is myoinositol and myoinositol and D-chiroinositol. So these are the two main stereoisomers. They act as precursors for PI3 kinase pathway, which is needed for the normal glucose metabolism. And they are also involved in calcium metabolism and oocyte maturation and development. So when we give myoinositol, it improves insulin sensitivity. And when the insulin sensitivity is improved, the glucose utilization is better. And as the glucose utilization happens, the insulin levels, when they are low, the testosterone levels will reduce, menstrual cycles will be restored, ovulation will be restored, and pregnancy rates will improve. So what do the guidelines say? Inositol should currently be considered as an experimental therapy in PCOS with emerging evidence on efficacy, highlighting the need for further research. So they have not strongly recommended. We can use it as an experimental therapy because of the benefits it offers. Then coming to the very important ovulation induction in women with PCOS. So the first line therapy would be using the oral agents, the ovulogens, which are aromatase inhibitors, that is letrozole and clomiphene citrate. Second line is gonadotropins or laparoscopic ovarian drilling. And the last resort, if these treatments do not work out, is IVF. So this is just to summarize how the actions of clomiphene and letrozole are different. So as we know, clomiphene citrate is a selective estrogen receptor modulator. So it modulates the receptors, it acts upon the pituitary, blocks the estrogen receptors, and because of which the body perceives that the levels of estrogen are low. In turn, what happens? The FSH levels start to rise, the follicle growth happens. And with the rising levels also, because it goes and blocks the receptor, the body perceives it as a persistently low estrogen levels. So the FSH goes on rising, and that's why the multifollicular development happens in women who are treated with clomiphene citrate. Whereas if you have used letrozole is an aromatase inhibitor. Okay, just 1 second. Dr. Asif, I'm in the class. I'll call you in 15 minutes. Sorry. So if we have given letrozole, it will act, it is an aromatase inhibitor. So it will inhibit the aromatase, and because of which the androgens are not converted into estrogen. So the estrogen levels will be low, and these estrogen levels will then then the pituitary will sense that, okay, the levels are low, so the FSH starts rising. And as the level rises, this action is overcome, and then the estrogen levels also start to rise. And that's why this is a very short-lasting action of letrozole. The levels, it has a very short half-life. So that's why the FSH rise happens for some time, and then the entire feedback mechanism again starts happening again, because of which there is not a persistent rise in FSH. And that's why in letrozole, we will get a monofollicular development as compared to clomiphene, where there will be multifollicular development. So like how long do we continue to use clomiphene in women with PCO? We can use up to 6 cycles, and the cumulative birth rates would vary from 50 to 60% for 6 cycles. If they do not respond to clomiphene citrate, what would be the option for us? So as you must be aware, what is resistance is when they do not ovulate only. After you have given for 3 cycles clomiphene, they document that there is no ovulation happening, then it is called CC resistance. While if you have documented ovulation with clomiphene, but pregnancy does not happen, that is CC failure. So in case of resistance, we would consider it for extended use, or we increase the dose gradually, or you can add metformin or myoinositols with that. We can consider adding glucocorticoids, or in the previous cycle, we can consider treatment with OCPs, which will reduce the level of androgens, and that's why the clomiphene will act better. We can consider adding antioxidants like N-acetylcysteine, L-carnitine, coenzyme Q10, or micronutrients. Vitamin D supplementation can be considered. And if they do not respond with CC, then we have to consider using gonadotropins, or then we might have to think of ovarian drilling as an option. And how would glucocorticoids help in this situation because they will reduce the adrenal androgen secretion. So there will be 40% lower peripheral androgens, and also there will be increase in FSH synthesis and secretion. The responsiveness to clomiphene will increase, and it acts indirectly by increasing the level of serum growth hormone IGF-1 and follicular fluid IGF-1 concentration. And how do we give these glucocorticoids? Usually we start from either day 1, 2, or 3, 0.25 to 0.5 mg in the night, and for up to 10 days, or some people even give it from the mid-luteal phase of the previous cycle. Then, as I told about how pre-treatment with OCPs would help, then how would N-acetylcysteine help? It is an acetylated precursor of L-cysteine and reduced glutathione. It lowers the testosterone levels, the LDL levels, and helps in regulating and bringing about the menstrual regularity, and helps in better ovulation. Sorry. It will also cause a pro-inflammatory cytokine release. And then the importance about having proper levels or normal levels of vitamin D. We can either give it as 1,000 to 2,000 international unit per day daily capsules, or weekly in as 60,000 international units orally. The goal is to keep the serum levels above 30 nanogram per ml. So this was a Cochrane review which was published about the use of letrozole in women with PCO, and it has been found to improve the live birth rate and pregnancy rates compared to clomiphene when it is used to cause ovulation and timed intercourse. The difference in miscarriage and multiple pregnancy rate was though not very significant. And based on multiple studies, that's why, and this is the ESHRE guideline again 2018, where they have emphasized that letrozole should always be the first line management for treating anovulatory women with PCOS whenever we are considering ovulation induction. Wherever letrozole is not available, or there are side effects or cost factors, or in certain countries it may not be available, in those cases clomiphene can be considered. If you have used clomiphene, they have not responded, or there is resistance to it, then consider adding metformin. Metformin alone has also been recommended as a pharmacological therapy, and many studies have shown that if you compare only metformin use versus placebo, or where nothing was given, metformin would give better pregnancy rates. So like rather than not giving anything, it would be better to at least consider giving them metformin. That itself will help in restoring the ovulatory cycles. And then the next resort would be gonadotropins. So usually gonadotropins are the second line management. So we have to always first try with the oral drugs, and then if that doesn't work, then go for gonadotropins, or we can consider laparoscopic ovarian surgery. And then the third line management would be IVF. So why gonadotropins? So when they have not responded, or they have failed to conceive even after ovulation with the first line ovulation induction therapy, then we have to consider using gonadotropins. And the point to be kept in mind is we have to always do the ultrasounds whenever we are giving gonadotropins, because of the risk of OHSS. And we must know when we have to cancel these cycles and when we have to trigger these women. That is when you need to give them HCG even for ovulation induction, when there are fewer than 3 mature follicles. And we have to cancel if you can see there are more than 2 mature follicles, and the patient should be advised not to have unprotected intercourse. And how would we use gonadotropins? Gonadotropins can be used in various different, there are various protocols for it. So we can either consider the low dose step up protocol, or a step down protocol, or a sequential protocol. And the main indication for use of gonadotropins for ovulation induction is definitely in women with PCO. It can also be used in hypogonadotropic hypogonadism, and also in unexplained infertility. So what are the various regimes for gonadotropins? This is the very conventional regime which is very often used. Start with FSH or HMG 75 to 150 and do frequent scans every 5 to 7 days. Check when the follicle is crossing 16 mm size or when it is becoming dominant. You can continue the same dose, and once it has become more than 16 mm, then we can consider giving the trigger. Whereas in the conventional step up approach, the starting dose could be 150 international units per day between day 3 to day 7. And we need to check for the follicle dominance, and whenever it becomes dominant, we continue at the same dose. If it is not becoming dominant, then we can increase it by 75, make it 225 per day for 3 more days, again do a scan and see, and based on that we can change the, so this is the step up. So we are gradually stepping up the dose from 150 and then increment it by 75. Then we have the low dose step up protocol. So in this conventional protocol, as I said, the starting dose would be 150. But when we consider the low dose protocol, it could be, we could start with 50 to 75 for 10 to 14 days. And then based on how the follicle size is, we can increase by either 25 or 37.5 and keep checking every 5 to 7 days until the dominant follicle emerges, and then we can continue at the same dose. Why would we use this low dose step up? Because it will give us higher rates of monofollicular ovulation, and because monofollicular multiple pregnancy will be lesser, OHSS risk will be lesser, and the pregnancy rates will be better. However, the problem, as you can see from here, 14 days plus 5 days plus 5 days. So the duration of treatment is quite prolonged. Then we have the gonadotropin low dose step down protocol. We start with 150 initially for 5 to 7 days, and then based on how the follicle is responding, if already one follicle is selected, then go on reducing by 37.5. So we reduce by 37.5 and then again after 3 days minus 75 till the HCG injection. And the advantage is that it will reduce the duration of treatment, but we have to more frequently call them for scans. Then there is the sequential protocol where there is an initial step up and then there is a step down. So the step up will be same to the low dose step up protocol, and then step down happens once the follicular dominance is established. Then we start reducing the dosage. So this was a study published where they had compared step up versus step down, and they found that monofollicular development was more with step up, and hyperstimulation was less, and ovulation rate was more with step up protocol. When would we consider laparoscopic ovarian drilling? This we have to always keep in mind, and always think twice before you recommend them for ovarian drilling, whether she would really benefit from it or not. So the cases have to be selected very meticulously, because we should not cause harm to them. Many a times women who have undergone ovarian drilling, they come to us with very low ovarian reserve, or they would have developed peri-ovarian adhesions. The tube would have got stuck to the ovary, and then the entire anatomy is distorted. So we should think twice before we are planning for lap ovarian drilling for such women. So we have to select them based on whether they have responded to our initial treatment or not, and preferably in young women, because there the reserve will be high. In older women, if we go and do ovarian drilling, their reserve is already on the lower side. It would further compromise the ovarian reserve. And then we must do the level of gonadotropin. If women who have high LH levels would benefit from ovarian drilling, or very high AMH levels also would benefit from ovarian drilling. Then if they have had exaggerated response, that is, if every time you try to give them even a little dose of gonadotropins, they hyper respond, so we are not able to give them any proper treatment, so then we have to consider ovarian drilling in them. or if you need to assess the pelvis for some other reason, say if you've done a HSG and you found there is some tubal block or some peritubal adhesions are suspected, or there is a fibroid, or for any other reason you need to check the pelvis, in that case we can consider lap ovarian drilling. Or if there is non-compliance or non-feasibility with frequent intensive monitoring, in those cases also we can consider lap ovarian drilling. How would ovarian drilling help? It will reduce the ovarian theca and stroma, and hence the androgen levels will be reduced, because of which the follicular atresia is reduced, the LH hyperstimulation is reduced, the inhibin levels are reduced, there will be rise in FSH and SHBG levels, which will reduce the testosterone levels, and it will help in restoration of the ovulation. So lap ovarian surgery could be the second line in women who are resistant for clomiphene, and when there are no other infertility factors, and it can be offered as a first line treatment if it is indicated for any other reason in women with anovulatory infertility and PCO. Then the last resort would be IVF ICSI, which is the third line when other ovulation induction therapies have failed. And because they tend to hyper respond, GnRH antagonist protocol for IVF has been recommended. And due to the hyper response, to prevent OHSs and complications, we should consider elective freeze-all policy for these women. And as far as possible in younger women, consider single embryo transfer of a day 5 embryo, and to reduce the metabolic abnormalities as well as to reduce the risk of OHSs. Even during IVF, it is recommended that we add metformin whenever we are doing controlled ovarian hyperstimulation. Then IVM is another treatment plan for them, that is in vitro maturation. So in women with PCO, if they are undergoing IVF ICSI, as I said, there is a very high risk of OHSs. They tend to respond to lower doses and many follicles start to grow. So in IVM, what is done is that the follicles are not allowed to grow till they cross like 17, 18 mm size. They are collected from small antral follicles before ovulation. So once the follicle reaches 12, 13 mm size, the oocyte retrieval is done. And then these immature oocytes are then matured in vitro by using IVM media. And then once they become mature, in that either you can do IVF, that is just culture the oocytes with the sperms, or ICSI, that is injecting the sperms directly into each oocyte, and then plan embryo transfer. Many a times, because they do not have hyperstimulation or the estrogen levels will not be very high, even fresh ET can be done, fresh embryo transfer can be done in these women. But usually when we do IVF ICSI, conventional IVF ICSI, we always try to do freeze-all, because we would have given them lupride trigger and we would not, the endometrium is usually out of sync. So we prefer to freeze all the embryos and do a frozen embryo transfer. So if we do IVM, it will reduce the side effects from gonadotropin stimulation. And so there'll be lesser chance of OHSs. The cost is low. The treatment is simplified. The discomfort is less, but the chances of success are also less as compared to ICSI. So these are my references. Thank you all for your patient hearing. We can take up questions now if any of you have any queries.
Doctors, any doubts?
Ma'am, can you just tell me step up treatment? Gonadotropin step up?
Step up. Just
yes, ma'am.
So you want to understand it again, is it?
Yes, ma'am. Yes, ma'am.
Okay. So in the conventional protocol, we start either with 75. Most often it is 75, that is 1 ampule. and that is given for 6 to 12 days based on the scan. Like normally we give for 4 to 5 days. We call them for a scan and see the follicle whether it is becoming dominant or not. If not, then we usually make it to 150 and continue it till the follicle becomes 16 or more, and then give the trigger.
Okay.
In the step up protocol, we start with a slightly higher dose, 2 ampules. Again, for 5 to 7, 5 to 7 days we can give and check for the same, and then increment it to 225. Here we are starting with a little higher dose and then incrementing also at a higher dose, like 75, almost like every time 1 ampule. So 75 will be 1 ampule. So 2 ampules like that, and then every 3 days we call them and then check and then change the dosage, again increase, or if the follicle has become dominant, then continue it at 225.
That means we have to start from day 3 only, ma'am. That
Yes,
one?
always day 3.
One
Okay.
second. You have given.
Then this is the low dose step up, where we can consider starting at 50 also. And
Okay, ma'am.
because we have started at a very low dose, they will usually require it for a longer duration. Clinically, what we use, is this one. The conventional is what we normally use.
Okay.
Or sometimes the step up.
That is from 6 to 12 days, ma'am. Day 6 to day 12.
No.
Then?
See, I'll just show you. You are still starting on day 2 or day 3 only. They have just shown that on day 6 you will check, day 12 you will check, and by say day 14, 15, the follicle would have become almost pre-ovulatory.
Okay, okay, ma'am. Okay.
And there is another regime which I had not told, we often use gonadotropins along with either letrozole or clomiphene. So first 5 days we would have given, like from day 2 or day 3, all treatments we start on day 2 or day 3 only.
Okay, ma'am.
So whether you're giving letrozole, clomiphene or gonadotropin, start from 2nd or 3rd day. And when we combine both, we start say letrozole, if I've given 5 mg per day for 5 days, either I can add gonadotropin on day 4 of letrozole, or sometimes we give it on alternate days also. Like 1 day 5 days letrozole will continue. Say it is day 1, 2, 3, 4, 5. So 2, then 4, then 6. On those days, we add gonadotropins. Yeah, alternate days gonadotropins can be added.
Okay.
So
that is also for 6 days, ma'am. This alternate
normally
days.
See, I would have started on day 2 or day 3, no, letrozole. So
Yes,
by day 7 or day 8, we usually call them for scan and see whether the follicle is growing or not. So if we have not given gonadotropins at all in the beginning, then we usually give for 2-3 days, either 75 or 150. Again, call them after 2 or 3 days and check. Or if I have already given like alternate days along with letrozole or clomiphene, then we would again call them on day 8 or 9, and based on how the size is, if it is growing well, then we usually don't add anything, because though these are the recommendations, but very often they, like in PCO, what happens, you start with a lower dose, then initially they will not respond. Suddenly they start responding. Many follicles start to grow, and then the cycle goes a waste. So be very careful. Like even if it is getting a little prolonged, it's okay. But do a proper ultrasound. That is very important on day.
Every 2 days once we have to do the ultrasound, ma'am. Then after giving the treatment.
Preferably, based on how they are responding.
Okay, ma'am.
If I say on day 8, I have already seen a follicle which is 14-15 mm. I know that this follicle will grow. So I will call them after 3 days only and check. But if I see the follicle is only 9.5-10 mm, then I would give them gonadotropins, again call them after 2 days. And again, though theoretically when you write your answers, you have to write like this only, that okay, this is how the conventional protocols go, like every 5 to 7 days. But normally we don't wait for so long.
Okay, ma'am.
Ideally, we should target that they ovulate between day 13 to day 15 or 16. So by then we usually take a call about the trigger.
Yeah.
Yes, ma'am. Thank you.